This is Talking Heads. Explore the latest in research and policy about serious mental health disorders with Dr. Noosha Niv.
Hi, I'm Dr. Noosha Niv, and today's guest is Dr. Marcia Hunt. Dr. Hunt is a clinical community psychologist and currently serves as a senior health services researcher at Rush University System for Health, focusing on aging and serious mental illness. She is also an associate professor adjunct in the Department of Psychiatry at Yale University Medical School, where she was previously an associate professor. Dr. Hunt worked at the Veterans Health Administration for almost 15 years, serving in multiple roles, including Associate Director of the VA Northeast Program Evaluation Center, where she was responsible for evaluation of programs designed to assist people with serious mental illness. In addition to program evaluation, Dr. Hunt's research focuses on the relationship between valued social roles and life functioning. Welcome, Dr. Hunt. Thank you so much for joining me. I really appreciate it.
Sure. I'm very happy to be here today.
Let's start with just like what led you to psychology and then more specifically the focus on serious mental illness.
Sure. I had kind of a funny path to psychology. So I was an architect before. That was my first job when I got out of school. I did that for about 6 or 7 years. And through a lot of different things that happened, I decided to shift focus and was trying to figure out and find myself. So I did some substitute teaching. And the place that they needed substitute teachers the most were the juvenile justice system in the temporary and transitional prisons for kids. And so that's what I did for about a year. And I spent a lot of time talking to the kids in there because I was teaching English and they were not really interested in, diagramming sentences, as you can imagine. Nobody's very interested in diagramming sentences, but their stories were amazing. Some were intensely sad. And I just thought, oh my gosh, who helps when people are in trouble like this? I was that naive about psychology and everything else. And so I started asking around and digging around, and I was like, oh, psychologists do that. Well, maybe I'll go be a psychologist. And so that's what led me to psychology.
That's a big change from architecture for sure.
It is, yes. I had one psychology course that I don't think I paid a lot of attention to in my undergraduate years. But once I decided on that and started taking some psychology courses and then trying to get into graduate school, I met my main mentor, Kathy Stein, and she's at Bowling Green and has worked with people with serious mental illness for a very long time. And through my journey, I found out that my grandmother had serious mental illness, and a really good friend of mine's brother that I grew up with had serious mental illness. And I didn't know it as that. I just knew them as them. And sometimes they had good days and sometimes they had bad days and sometimes they were confusing. And so that kind of cemented my interest in that and my wanting to help out where I could and learn more about it.
Wow. So there was definitely that personal component.
Yeah, that I didn't realize until later. Yeah.
And what did you end up when you were working with Kathy Stein, and what were you studying at that point?
Well, she was a clinical community psychologist. So that's sort of my bent. I'm interested in working with systems and systems of care that help people sort of through understanding what those people want and need. We were taught a lot by individuals in the community with serious mental illness. We would partner with them to make changes with things, whether it's in day programs or in hospital settings or just generally understanding their life and life course. And so I was a student of the folks in and around Bowling Green for a long time and worked with them there. And then that passion for making systems change and elevating people's voices stayed with me.
So those system changes sound like it was really driven by the people you were working with in the community rather than kind of top-down research.
Right. Absolutely. Now, that's not to say that we didn't apply research methods to things to help get people's voice out. So we did a lot of qualitative and quantitative combined stuff for people to be able to, in different ways for people to share their stories, right, through questionnaires, which are great, but not as rich as people's stories, I think. But the idea was we would utilize those data to talk to the community agencies to help them move things forward. So did a lot of program evaluation and different things like that as well, with all kinds of systems. I worked a lot with housing.
And is that, when you talk about some of the changes, were they practical changes that people using these services could really notice in their day-to-day life?
I think so. Actually, both pieces. People providing services get confused and end up doing things that people don't really want, and people receiving services don't understand why they're not getting what they need. And so we sort of helped people come together. The housing agency that I worked with, I learned so much there. We started out by trying to help the agency understand better what their case managers did to help people. So it became really apparent that a main thing that was going on was centering around how close the relationship was between the case managers or care managers and the folks that lived in the apartments, to the point that some of them lots of them had pets. And this was a no pets kind of place.
As most places are.
Most places are. And the pets were, understandably, if you're a pet person, I have dogs, they're very important to you. So we helped the agency make changes to implement a pet policy in a way that they were comfortable with, because they were very uncomfortable with pets, and in a way that helped support the pet owners and tenants, so that they could come out of the shadows with their fish and birds and cats and dogs.
So you got the agency to accept pets as a,
Mm-hmm.
and you wrote a paper on this and found some really clear themes that emerged from interviews with these folks. Can you talk a little bit about what those themes were?
A lot of it was that it's a valued social role, being a pet owner, right? You're providing care for that pet, and you're making sure that they're doing well. And when we have valued social roles, they help us feel better about ourselves, all of us.
So a sense of responsibility.
Sense of responsibility, yes. And you meet people that way. Your picture of your cat's on your phone and somebody sees it, and now suddenly you are having the role of cat owner, talking to another person in the role of cat owner. And, you're in the park with your dog. And so it helps you make social connections. Pet ownership does. It helps you have that valued role. It helps you provide care for something and feel needed and wanted. Even if you don't have other people or things in your life, you know that thing loves and wants you, whatever it is, a fish, a cat, a bird. So that's really important. And that was a main thing that came through.
That sense of connectedness and the sense of being responsible for something or someone else.
Absolutely. Yeah. And just being valued by them. I mean, there's nothing nicer than coming home and having your pet be thrilled to see you.
Right. And if you don't have a spouse or kids, or, and as we know, a lot of people with SMI are fairly lonely.
Yeah. Yeah. Or even if you do, I mean, I have a husband, but he doesn't greet me in the same way my dog does.
It's that sort of unconditional connection.
It is that unconditional connection. It really is important. And so that sort of thing came across loud and clear. And that's why I think you talk to people who don't have a house and are living on the street or living wherever they're living. And if they're offered a place where they can't bring their pets, often they'll say no. It's not worth being housed if I have to give up, my family member.
So I'd rather be homeless and have this animal that I love.
Absolutely.
Than to have stable housing, but have the significant loss.
Significant loss. Absolutely. Like giving up your family member.
This is such an interesting, I had never read anything in this topic. There's just not much research in this area, is there?
No, sadly. Yeah, because it's very important. You do see more in the housing literature rather than in the serious mental illness literature, but we're all people. We all need places to live. Many of us have pets. And so I think we forget that people with serious mental illness have the same wants, needs, and desires as anybody else that doesn't have the label. And so you're going to find pet owners, and you're going to find, every flavor of person like you would in any other group.
You talked about advocacy. You've actually written quite a bit about the recovery movement and its connection to social justice movement.
Yeah.
and how they are similar, but also not necessarily serving one another. First, let's talk about that connection. What is that connection?
Yeah, well, historically, the recovery movement really grew out of a very strong advocacy work that people with serious mental illness pushed, right? The nothing about me without me part of the movement. And so, everything has a life cycle. So the recovery movement had a life cycle too, right? It was birthed in advocacy, and then it developed and became a little more concretized, and people worked very hard to get it embedded into systems of care. But when you embed things into systems of care, they become institutionalized, and the institutions then take them from the advocates, and they begin to write their institutional policy and things like this, hopefully involving the people that were part of that advocacy movement, but often kind of moves along without it. And when things become institutionalized, some of the passion falls away. It becomes everyday now. And there are good sides to that. So recovery as an everyday thing is a very good thing, right? All of the premises of recovery institutionalized into policy is a very good thing. But I think now we're ready for the next step with that. And I would love to see more advocacy coming out of the grassroots of people with lived experience saying what's next. Recovery is a terrific first step. Let's make sure it's everywhere. Next.
I want to get to what's next, but when you talk about it loses some of its passion, so it sounds like it's kind of diluting what you think were the intended consequences of that movement. How is it doing that? Obviously, especially when big organizations or mental health community clinics or government organizations primarily, it adds a lot of regulation and bureaucracy. That's certainly part of it. But is there something else that you're referring to with that kind of dilution of the energy and passion behind it?
Yeah. And I think it really is about that bureaucracy. When the bureaucracy works, it's a good thing. But often the voices are lost. So you still see people, clearly you still see people in institutions of care that have checked the box that their policies are recovery oriented, and the people's treatment on a day-to-day basis does not necessarily align.
It doesn't reflect what they actually want.
Right. Necessarily. And even how the policies themselves are interpreted and implemented. I have a fantasy of taking modern day policies and talking to the original people who started the advocacy work with deinstitutionalization and saying, is this what you wanted? Is this where you were headed?
Is this aligned?
Yeah. Did we go off path? Are we wandering in the wilderness now?
When you talk about kind of they check the box of, yes, we're doing this. I remember I consulted with a clinic once that was like, yeah, we do recovery-oriented care. And what they meant by that is they asked about it in their assessment, but then they didn't actually offer any of the interventions that might get people towards those goals they identified in the assessment.
Right. Absolutely. Absolutely.
How is that going to work?
Exactly. I've seen that so often.
So often. Like, asking isn't enough. We got to actually do the work.
Exactly. I had very similar experience, doing program evaluation, and people would say, yeah, right. We asked people exactly what they want because we're going to tailor programs to them. And I'm like, cool. Well, it looks like this person wanted X, Y, and Z. Do you guys offer that? No. We offer 5 things. And I'm like, but do they shift based upon what people have said? Well, we can't really do that. And I'm like, I think we've missed the point here.
And my guess is that from your experience, my guess is what those 5 things they do offer really are geared towards symptoms rather than what people are asking for.
Absolutely. Yeah.
Where would you like this to go? When you say go to the next thing, what does that look like? And who can help do that work?
Yeah, I don't even know if I'm in a position to answer that, because I really feel like it's people with lived experience in the world today picking up that banner and saying, okay, now this is what's needed. I can work to put myself in that position, but if I've never had to live it, I can only guess and, base it on what I think. I think it's about voice, right? So part of it is not just having a board or having peer providers or having a group look at policy. I'm not saying that's not important. It's really important. It's necessary, but not sufficient. So I think the next step is asking, where does our organization go now? What do we need? What should we do with whoever's willing to step into that role? And frankly, people need to be paid for it. People are acting as consultants by helping organizations change. Then consultants get paid money. Can't we pay these people money if they're consulting? I'm just saying.
And more than just the, like, here's $20 to be in a study, right? Like, to really come in and do that work takes time and effort.
Exactly.
Can I back up? You and I think we have an understanding of what lived experience means, but what does that mean to have lived experience?
Yeah. So I guess to me, it means having a label, rightly or wrongly, that you've had to move through the world with. So, because that makes a difference on top of any symptoms you might have, anything like that. And I say it makes a difference because I think about my grandmother, and my grandmother had bipolar disorder. I'm pretty clear about that, but she never had the label from a medical person, somebody who could diagnose, because they just didn't back then. She just was moody. She's very moody. And she had really, really, really bad days and really, really, really good days where she was a lot of fun.
Yeah.
And so when I think about her experiences of living through the world, she had to live with those symptoms, right? She had to live through those really bad days and those really good days and how she took care of her kids and everything. But she didn't have to struggle with the label on top of it. Mm-hmm. So I think it's a combo. It's whatever is going on in your life and your body, and whatever label we hand you in our systems of care that you then have to also cope with.
Right. And that label is going to produce different outcomes in different settings.
Absolutely, because you get treated differently.
Right. You talked about, you didn't word it this way, but in terms of like patient-centered care, that's, at least that's how I kind of conceptualize how you describe this. What are aspects of patient-centered care that you think are important?
Yeah, I think the main one is, as a provider, being humble and realizing you've got a skill set. Like everybody's skill set, it's limited, and you need to figure out what parts actually help the person in front of you. And that's being person-centered and being humble enough to say, wow, I've got, a wrench and a screwdriver and a hammer, and you need a tape measure and caulk. So I need to find somebody else who we can partner with to do those things, as opposed to saying, no, I have a hammer and a screwdriver. Clearly, you have a problem that is either a nail or a screw, and we will be doing that.
Got it. So I'm going to force the thing I know how to do on to that.
Right.
But part of that is also giving people a voice in their treatment, right? And I think this is a real challenge because so many times you see a therapist or a medical doctor and they're the expert.
Absolutely.
When they're the expert in terms of like book studying and maybe experience with their clients, but ultimately the patient is the expert in themselves. So how do you bring their voice into a session?
Yeah. Well, I think, like I said, I think it starts with being humble, right? So your expertise, if you are really good at hammering things and screwing things in, you have to realize that, and you have to realize that the person in front of you is their own expert. If you have to keep remembering that if you're hearing something from them and you're thinking, I don't think that's true. I think it's really something that I can use my hammer on. You need to realize, take one step back and say, listen to them. What is that need? I think you can only do that realizing your own limitations, and that's always a dangerous thing, like emotionally dangerous for people. I think when we think about our own limitations, it's like, I don't want to think about that. But you have to do that before you can help raise their voice, because if you think about it, if I'm the expert and I know everything, and you're sitting there listening and thinking, yeah, but that doesn't work for me, it's too easy for me to squash you and say, whether I'm intending to or not, to squash you so that you think, well, I'm probably wrong. I should try this one more time, even though it hasn't worked the last 15 times I've tried it.
And what we've called that in treatment has changed a lot over years. But I think today most of us would recognize that as shared decision making.
Yeah. And that has good ways to do it and checkbox ways to do it. Right?
Tell me about both. What do you see let's start with the not good way, the checkbox. Right?
Sure.
What does that look like?
I've talked with some folks about this, and I'm always surprised to hear that their definition of shared decision making is, I tell you what I think you need to do, or medication you need to take, or whatever. I let you say what you think, and then I'll write you a prescription
we do it
for that medication. Yeah. Okay. So I said something, you said something, we shared it, and now here's what you do. It's a little exaggerated, but I think it goes a little bit back to what we were talking about with programs. If you ask the question, right, if you're going to have a discussion about shared decision making, then you, the professional, the expert in your area, may not like the decisions that the person makes, because you may think you can see down the path and see how it will turn out. Maybe you're right, maybe you're not. But you have to be able to say, okay, here's what I see are the risks. Here's what I see are the benefits. This is what you're telling me. If I'm right, and those are the right risks and the right benefits, are you good with that? Right? That kind of approach where it really is just a weighing out, because ultimately it's the person you're talking to's life. They have to make those decisions. You can't make them for them. Just like I couldn't say, no, you have to go live in an apartment without your pet because it's better to have a roof over your head than to have your animal. That's not my decision.
And ultimately, if you don't have buy-in, they're not going to follow through, right?
Absolutely.
Would you?
I certainly. Yeah, I've talked to my doctor, and they're like, oh, you should really, exercise every day. And I'm like, yeah, you're right, I should. It's never going to happen. I'm sorry.
Right. Exactly. So. One of the things when you talk about the hammers, nails, and all these tools, is what it brings to mind is, one, clinician being humble, but then also having the resources to then say, I don't have the tool set you're looking for, but having access to someone who does.
Absolutely.
And that is hard. Part of what you're talking about is a group of people working together.
Yeah.
And there aren't many systems that actually work that way.
You're absolutely right. And even less if you're a private practitioner, because I've been talking a lot about folks maybe want to get therapy in the community, and very few private practitioners feel like they have the connections or the tools to help out, whether they do or they don't. But I think it is very hard to have a group of people, which I think is the best way. I prefer my healthcare with a group rather than a singular person. And I'm not sure what to do about that without really large system changes in our entire country.
Because that sort of coordinated care you might get in a larger system, such as the VA. But I think it's really hard if you're in private practice, you're not going to have that sort of coordinated care, are you?
Not unless you work very hard to make those links. And I think that's where, if we're talking about leveling the playing field in healthcare, we need to understand that doesn't just mean for people who have small things going on with them at any given time. We need to be able to accommodate people who have large physical health concerns, large mental health concerns, and or both, and aging and dementia and all of the other things that happen to us in our lives. And we're not set up for it. We're just not.
Not at all. So we really need to make systemic changes to how healthcare is delivered.
Yes.
In order to meet that need. So, I don't want to be pessimistic, but I think that's where you talk about advocacy is needed to make that happen. But that's kind of a big picture, longer term goal.
Mm-hmm.
Today, I am seeking treatment. How can I advocate in my treatment setting to at least get a modicum of that?
That's a really good question. And I think it's very tough. That's the sort of unfair thing about self-advocacy. Nobody asks you to advocate for yourself when nothing's wrong. Because you have nothing. You're in the middle of a healthcare crisis one way or another, and that's when you're supposed to advocate. So
it's a terrible place to be.
It's a terrible place to be for anybody. So I think the best you can do is take somebody with you that you trust. Take somebody with you that's not coping with whatever it is you're coping with, so they can be your voice. And that means making sure the people that love you or even the people that don't love you that are willing to help out, know your wishes, right? That know your advanced directives, essentially, mental and physical health, that they're able to push for you when you can't, or you're just giving up.
And if I'm just new to getting care, maybe it's not an emergency setting. Maybe I'm trying to get connected with community mental health care.
Yeah.
I suppose one way is to inquire up front about, is there a psychiatrist, a psychologist, a case manager, and people with different expertise. But most people don't know what to ask for in that regard.
Absolutely. And that's where I think, talking to other people who've been through things is really helpful. Really helpful.
And how can people do that? Get that sort of peer support?
Yeah, the peer support. Well, it kind of depends on where you are, but there certainly are groups and other advocacy groups. It's kind of, you can, thank goodness for the internet, you can look up a lot of things on the internet and find some help that way. And then, like everything else, it's the trial and error piece. Talk to somebody. Does it fit? It doesn't fit. Talk to somebody else. Does it fit? And just kind of try it out.
We've talked about peer support kind of more generally, but in terms of including peers in actual treatment, there's been a lot of research on that. Are you, in your work, have you seen whether people do they like those experiences? Do they not like them? Do they want the professional, or does having the peer really help make the experience more relatable and get them more engaged?
It's a really good question. I have to disclose my bias. So I have worked with some amazing peers. So I have worked with very few lemons. I've worked with a lot of superstars. And so what I have seen from my superstars, there's nothing like working with a peer provider. Ever since the very first guy that I ever worked with on my team, I was revamping a screening clinic and trying to help teach incoming psychiatrists, psychologists, social workers, as well as screen people for healthcare needs. And he made the whole thing work, frankly. People would come in and they're anxious, and he would be able to sit with them and talk to them, be like, look, I've been here. Let me tell you. And really kind of make them feel like, okay, if this guy is part of my team and he sort of runs between me and the other providers, how bad can they be? I think he can keep them in line. And that's exactly how he worked. And so I'm a big fan of peers.
It increases that trust, doesn't it?
It increases the trust. It decreases anxiety. So our peers were part of the team meetings afterwards, where we're trying to figure out, okay, you were able to talk to the person. The peer was able to talk to the person. Here's what we think we can do for them. And he was very strongly able to take their voice. You tell people different things depending on who they are. You may tell your primary care person about the ache in your toe, but if you're going to go see a heart specialist, you're not going to mention your toe. Same thing. In the waiting room, they would talk about their lives in a very different way than in a clinical interview. And so we were able to put those two pieces together. He was able to say, oh, no, that will not work, and here's why. Or that would be a good thing, I think, from what he said or she said.
So they'll just disclose more.
Different things.
But that's that trust piece.
Yes, that's the trust piece, and just the kind of, I think, level of comfort and decrease in anxiety.
In what a hopeful thing to see a peer.
Oh, yeah.
When you're struggling, to see someone who's gone through those same struggles or similar struggles, and to see that they are working and helping others, and in a place where they've made some gains in that area.
Yeah, really helpful for the person who's struggling with illness themselves, and really helpful for the system, because the system can get jaded. When you come in for acute care for something, they see you at your worst, right? They see you with a horrible infection. They see you with symptoms you are not coping with. They see you with all these sorts of things, and they see the next person that way, and the next person that way, and the next, and pretty soon your window of the world narrows to, oh, everybody must have a really horrible infection. Everybody must be trying to cope with symptoms that they can't cope with. And that's not true. So peers also provide hope to the system.
I think this is going back to that patient-centered care. I think it's really easy as providers when your scope becomes so narrow is you don't see people as individuals in the same way right anymore, right? You see their diagnosis, then we all think we think they're going to have the same exact thing repeatedly.
Exactly. It's kind of like the surgeon that you hear say something like, bring in the next knee. Well, it's not just a knee, it's actually attached to a person, Right. Yeah.
I'm going to switch gears. You've mentioned physical health intermittently, and you brought up dementia, and dementia and psychosis can look similar in a lot of ways.
They can.
And how do you go about kind of untangling the signs and the symptoms of these two very significant difficulties?
Yeah. I think that's a really good question, and one that you kind of have to go back to the history of the person. I think, most folks who develop psychosis early. There are some people who develop it later in life, but if you're a provider and you've been around someone who for sure has dementia, and you've been around someone who's for sure got psychosis, then the feeling is wildly different. So on paper,
you mean how it presents?
How it presents and how it feels, right? So when you think about a delusion, so I think about my mother-in-law. She had pretty progressed dementia, and I knew her through the process. She had lots of delusions, and her delusions were around people coming into her room, people scaring her in a particular kind of way, and people taking something that she had. Right? Taking a piece of jewelry or taking a book or taking something. And she was very worried about that. And we checked those out because that's also important. It's only a delusion if it's not actually happening.
Yeah.
Right? And sometimes they really happen. But so she had that going on. And then I think about other people I've known in my life who've had psychosis, and their delusions are very different. They may also feel unsafe, but they feel unsafe in a very different way, and they'll express it in a very different way. And so that flavor is different. The timeline is different.
It's rare to see much older people develop schizophrenia.
It is.
Right? It's not to say it doesn't happen, but it's pretty rare.
What is not rare is the fact that in nursing homes, at least, people develop the diagnosis of psychosis and schizophrenia, because if you have a diagnosis of a serious mental illness where an antipsychotic is a suggested treatment, dementia, it's not. But it's a great behavioral restraint.
So they'll get that diagnosis just so they can give them medication.
Yes, so they can give them medication. And it's a pretty well-documented increase in this over the last 10 years.
Is that because they can't give antipsychotics off-label?
It's a workaround.
And so they get this diagnosis rather than the dementia diagnosis.
Well, they have a dementia diagnosis, and now all of a sudden they have a diagnosis of schizophrenia at age 68 with no previous symptoms. And frankly, I'm not necessarily convinced that without stretching it, they meet criteria for that either. But
aside from the dementia piece, what are some things we need to think about when working with older adults with SMI?
Yeah. Well, I think a lot of it is the same kind of thing that you think of as your aging period, right? You're going to have sort of a 1-2 punch. I start to say something about valued social roles. So valued social roles in our lives are tied to the timeline of our lives. So when you're younger, you're a student. You're not often a student later in life, right? Later in life, you have a job of some sort, possibly. When you're 7, you don't. So you have different roles at different times in your life. And, there's a childbearing age and there's a non-childbearing age. So these shift as we go. The tough thing when we think about psychosis, particularly schizophrenia and other serious mental illnesses, throws you off that life trajectory oftentimes. You're not dating at the same time other people are, perhaps. You're not starting a family at the same time, or maybe not at all. It just shifts you out of what society thinks of as normal.
These are typically delayed or don't happen at all.
Exactly. Typically delayed or don't happen at all. So if you have that, and then if you have a normal life progression where now you're past an age to be a parent, and now you're past an age to do whatever. As we get older, those roles change and decrease. Right. And so you've got a 1-2 punch. You may have been thrown off trajectory with delayed or things that didn't happen for you. And then as you get older, even the opportunities go down. So I think we have to think very much about that layering of lack of opportunities or opportunities that seem to be shifting and changing. Some of that is based very much on society's view of ageism and other isms related to folks that don't seem to fit the exact same Barbie and Ken mold that, society holds in their head. I think just being aware of that and being aware of what it means to have to cope with this off-timedness and lack of opportunity, some governed strongly by society, some biology, but I think that's really, really important to think about when you're working with people as any age, but as you go through the life trajectory, and the fact that making meaning in your life and, thinking about who you are at any given time in your life as roles change, it's really important.
Thinking about how that would look in therapy, but also thinking of how that might look with family members is to help create opportunities, even if they don't fit that traditional timeline.
Right.
But also giving people an opportunity to grieve that not having achieved.
That's right.
Whatever they may have wanted to achieve, but couldn't.
That's right. And I think normalizing that.
Yes.
I think it's very difficult when you're in the depths of your grief around things like that to feel like it's just you. You're the one who lost. You lost out. Everybody else got it and you didn't. And so I think saying, yeah, that really stinks. And it has happened to other people and they've managed and they've made different meanings in different ways. And, whatever it is, maybe you desperately wanted a kid and you didn't have one, or maybe you desperately wanted a job or a particular kind of job and you didn't have it, or whatever it is.
Right. And it's okay to grieve that and know you can cope with it. Those aren't mutually exclusive.
Right. It's not just you. And it's more than okay. It is normal.
Mm-hmm.
I mean, I'll bet you there's not a person who's gotten to some point in their life and gone, Dad, come on, never, whatever, right?
Right. And this is not SMI specific, obviously.
It isn't. It's a person thing. And I think that's, realizing that a lot of what we talk about, a lot of people deal with, those are natural changes in life. Unfortunately, if you have SMI, you get to layer all that other junk over the top of it. It doesn't lessen all those other losses. It just means you have this and another basket of stuff to carry too.
We talked a little bit about loneliness, and generally as we age, we can get more isolated. Again, not SMI specific, but again, can happen even more in that population.
Yeah.
How can we help prevent that? Because we know that social contact is really important, both mental health and physical health.
Yeah, I think that's a great question. I've done a lot of thinking about this from both perspectives, both an aging perspective, an SMI perspective, and a combined perspective. But I think it's important to remember that loneliness and lack of social interaction are not necessarily the same thing, right? So I think that's important. I hear my mother in my head saying, I'm not a joiner. Don't make me join things, right? So some people are just not joiners. It's just the way they are. I think we have to also recognize that people's social interactions come in many, many flavors. Sometimes sitting at your window, watching the postman come and go is your social interaction and you like it. Sometimes sitting in your window, watching the postman come and go is your social interaction and it's not enough. So I think it's important to realize that while you haven't gone out to the movies or to find friends, that may be a real problem for some people and something to work on. And for others, it's more like, have you gone to the grocery store and seen that checker that's funny and always has those weird fingernails? Or maybe that's just my checker, but that's an important piece of interaction for a lot of people's days.
And the research supports that in that it's not necessarily like the number of friends you have or how often you go out, but it's your satisfaction with those interactions that you do have.
Exactly. And I think that's part of being my bonnet around community integration with that too. I think too often we talk about community integration as the number of things you did somehow, right? How many times you go to the coffee shop? How many times you go to church? How many times did you blah, blah, blah? But I think community integration is much more of a feeling. Watching that postman, talking to that checker, And maybe it is going to town halls for you, but I think it's that feeling of belonging. I know I belong because, right? I'm integrated in this community because, or I'm not because. And so that's very individualized. And I think we have to recognize that as well.
It's not a quantitative.
It's no, and it makes it harder to study. I get that, believe me.
Yes.
And so we like nothing better than counting things and comparing this total to that total, or this average to that average. I wish it were that simple, but I think in reality it isn't.
I have a couple of questions from my Facebook group for you. First one, my grandmother is diagnosed with schizophrenia. We were recently told she also has dementia. I'm not clear on what type of care she should be getting. Who should she see for treatment?
Wow, that's a tough one. I would start with someone with a gerontology specialty. So a geropsychiatrist, a geropsychologist, preferably both, or a team of gerontology specialists.
Okay.
I think would be the best bet. And there's some really good folks that specialize in serious mental illness and dementia.
That's good to know. Okay. This, we touched on this a little bit, but I'd love to hear your answer. Dr. Niv keeps talking about the importance of shared decision-making and finding a therapist that honors that. I don't understand what that means when my husband is so sick. I'm taking him to an expert to make those decisions, right?
I hear you, because I've said that to myself when I go to my gastroenterologist. I really just want them to tell me what is best to do. And so I think you can say that and say, I need your expert opinion. Were you me, what would you do? Because I feel lost here and I need that. And we can talk about whether or not I will do it, right? Like what's my buy-in and can I? But sometimes the expert piece needs to come out, and I think that the care provider needs to understand that as well.
And that can be frustrating for a family member, right? If their loved one who's ill is not going along with this expert advice.
Yes.
And so how do you sit with that as a family member?
That is really hard. And I think that's where the rubber meets the road with autonomy. So if you said to me, are you a fan of autonomy or a fan of paternalism? I'd say, oh, autonomy. Until you said, okay, your mom has congestive heart failure and she's, not taking her medication. I'm like, paternalism.
Right. And she's smoking on top of it.
That's right. Nonstop. That's right. Did you know my mom? But yeah. So I think that is, gosh, it's such a personal thing. It's such a personal decision. I know that for myself, I tried to take over and push. I tried to explain why. Right. When I would do, and it really was my mom, I really was trying to push her behavior and was letting her know I wanted her to be around. And, sometimes she would not. And most of the time she would just go do what she was going to do. And so it was left to me to sort of resolve it internally. But there is no answer to that.
It's a tough one. And it's a tough one when you're a spouse or someone actually living with the consequences of someone else's decision.
Absolutely. Absolutely. And I think at that point in time, you have to also think about how do you care for you? Not that you shouldn't be thinking about that always, particularly in those situations where you have little power and control over things that are impacting you. What do you do to take care of it? And how do you sort of shield yourself from those decisions if that's what's happening?
And maybe that's not feasible and you have to set boundaries for yourself.
That's right. Absolutely. And that's part of the shielding, I think, right? Is setting those boundaries. Like you can be supportive in lots of ways, and boundary setting is sometimes one of them, because sometimes what people need to hear is, you know what? No, line in the sand. Mm-hmm. It can't happen anymore, or it can't happen with me around, or whatever's going on. And then sometimes that helps the person shift sometimes.
And to think about maybe reframing it as, what are your goals? Mm-hmm. And will doing what this doctor is saying help you and us as a family get closer to them?
Exactly, to those goals, and reminding them. And I think sometimes when we're asked about our goals, sometimes we say what we think people want to hear. So you may have to be cognizant of that when you're talking with someone around that and helping them set their own boundaries. And I know from my own personal experience and working with my family and loved ones that I know what I'm supposed to say. So my goal is to feel better. but you got to dig a little deeper because that's not going to motivate me.
No. It's usually some sort of something to do with friends or a job or my relationship with my kid or something a little more nuanced than feeling better.
A little bit more.
Yeah. Last question for you. What are you most excited about in the field of psychosis? What are you seeing as really the thing that has the potential to impact lives and improve outcomes?
That's an interesting question. I think it really is, for me, the expansion into so many areas of peer providers. It really is. I loved, like I said, working with them. And I feel like that peers in as many settings as possible, as diverse as possible, will maybe shift us to the next place. And maybe they're the ones that pick up the advocacy banner and move forward to shift the system next.
Well, I look forward to see where that goes. Thank you so much for your time. It was lovely having you, and I love chatting with you.
Yeah, me too.
Such a unique way of looking at this field, and I really am grateful for it.
This is Talking Heads.